Okay, so now let's cover the diseases of the bone. And in the diseases of the bone, the first disease that we have is the Paget disease. Now, the Paget disease, first of all, is general introduction that it is a disorder of the bone remodeling. So you will see that it is a disorder of the bone remodeling, and it is due to the osteoclast dysfunction. So mainly the main thing that will be involved is osteoclast, and secondarily disorganized bone formation. And after the osteoclast dysfunction, there is secondarily formation of the bone which is disorganized, and then that thus makes this disease a disorder of the bone remodeling. So basically, you know that there are osteoclasts and osteoblasts in the bone. So the osteoblasts are the bone forming cell, whereas the osteoclasts usually resolve the bone. So in this disorder, what will happen that the osteoclasts, they will dysfunction, and once they dysfunction, so they will eat up a bone, and that junk will be produced again by the osteoblast in some disorganized manner. So this this disease will happen, that is called the Paget disease, and it is a disorder of the bone remodeling. Now hence it is also called as osteitis deformans, since disorganized bone is formed, and it is usually seen in late adulthood when the age is greater than 60 years. So it is a disease of the elder people. Pathogenesis. So normally, first of all, the normal physiology that we know, that there is a balance between osteoblast and osteoclast activity. So the blasts are continuously forming the bone, whereas the clasts are continuously resolving the bone. Now the osteoclast activity normally depends on the osteoblast. So when the parathormone parathyroid hormone receptors, which are found on the osteoblast, so when they activate the osteoblast so what happens, the parathyroid hormone act on the osteoblast. What happens then, the osteoblast express rancor, the receptor activator of the nuclear factor kappa b ligand. So they express this ligand, and this ligand then activates the class by binding to the rank the receptor activator of the nuclear factor kappa b. So in simple words, the parathyroid hormone, it act on the blasts, and once the blasts are activated, then after that it activates the osteoclast, and that osteoclast then resolves the bone. So that is the normal physiology, normal way of the resolving the bone. But here what happens, that in this disease, due to some virus, and it is a supposed theory, not a definite definite etiology, but it is a supposed theory that the virus paramyxovirus, it activates the osteoclast. So once it activates the osteoclast, it make it crazy, and what happens that the osteoclast continuously resolves the bone. So once it continuously resolves the bone, so what happens that a lot of bone is lost, and once a lot of bone is lost, it is sensed by the blast, and the blast start forming the bone very quickly, and this quickly formed bone is not very strong. So fractures occur very commonly in this bone, and what happens that these fractures will then cause pain. But and the main thing is that this disorganized this bone that is formed in rush will be disorganized bone, and this disorganized thick sclerotic bone is what is a characteristic of the Paget disease. As we have said, that the Paget disease is a disorder of the remodeling, of the bone remodeling. So here the bone is remodeled in a disorganized way. And some genetic factors are also involved, such as STM1 gene mutation also occur in this disease. Let's talk about its clinical feature. So the clinical feature is the main feature that will be present, that is the bone pain, and this bone pain is mainly due to the fracture, since we know that this newly formed bone, it will be thicker but it will be weaker. So fracture occur most commonly in this bone, which leads to the pain. Moreover, there will be hypervascularity. The hypervascularity to the bone, that will cause the overlying skin to become warm up a little bit. So so that area will be inflamed. The next thing is, since the bone newly formed, since the bone is continuously forming, so what will happen, that the person's head size, and that will be mainly diagnosed by he will come to know it by that he will having and increasing head size. Moreover, there is a platybasia, that is the invagination of the skull bone, invagination of the skull base. So invagination of the skull base will also occur, that is called as platybasia. Now what happened, the osteosclerosis of the temporal bone, that will lead to the conductive deafness, and so once there is impingement of the auditory nerve, that will also lead to deafness. So since the temporal bone osteosclerosis occurs, so what will happen, that the nerve inside going so that will be trapped, and as a result deafness will occur. Moreover, if there is involvement of the craniofacial bones, that will lead to the line like facies. Okay, so these are the various clinical features, but the main feature is the bone pain. Complication, what complication can develop in this? So first of all is the high output cardiac failure can develop, osteoarthritis can develop, and osteosarcoma, which is a rare but very serious complication. And in osteosarcoma there will be increasing pain in the bones, and there will be swelling of that particularly localized area. So these are the various complications that can develop in this disease. Okay, now let's come to its management, that how will you manage the Paget's disease. So the management, just make a general concept that in the management you will first diagnose it and then treat it. So for the diagnosis you will have to start from the history, then go to the examination of the various signs. In the history you will ask for the various symptoms and signs, then examination, and after that there will be investigation, and in investigation go through the general uh, order of, first of all go for the blood investigation, then radiology, and then histopathology. So first of all, since I will skip the history and examination, so we will go to the investigation. So in the investigation there will be isolated increase in alkaline phosphatase. So isolated increase, what that means, that the serum calcium and phosphate levels will be normal. There will be only increase in the alkaline phosphatase. Now why will be there an increase of alkaline phosphatase? There is a general concept that whenever you lay down bone, so the for the in order to lay down bone, we will require an alkaline environment, whereas on the contrary an acidic environment is required to remove the calcium. So in order to resorb the bone, in order to for the resorption of bone, we need acidic environment, that is provided by the carbonic anhydrase in the osteoclast. So the carbonic anhydrase in the osteoclast, it supplies the acidic environment, whereas for in order to supply the alkaline environment we need alkaline phosphatase. So this enzyme is increased, and as a result what will happen, that there will be increase in the serum alkaline phosphatase, whereas the serum calcium and phosphate level will be normal. There will be an increased urinary excretion of the hydroxyproline, and there will the X-ray. Once you do the now you will come to the radiological investigation. So when you do X-ray, what will happen, that the bone expansion will be seen, since the bone is increasing, large thick sclerotic bone will be formed. So the bone expansion, and moreover alternating areas of the radiolucency and osteosclerosis. So some areas are getting eaten up by the osteoclast, so they will look a bit radiolucent, whereas the other areas will be that will be thick form bone, so that will form the give the look of the osteosclerosis. And if you biopsy the lamellar bone, is of mosaic pattern, and as the summit lines are not fused. So you know that the the outside lamellar bone and the inner medullary bone. So the outside lamellar bone, there are compact lamella whose lines fuse with one another, but here the summit lines will not be fused with one another because the bone is formed in a rush. Okay, so this basically, just remember the X-ray, that on X-ray there will be bone expansion, and there will be alternating areas of the radiolucency and osteosclerosis. Finally, come to its treatment. So just remember that the first line treatment for the osteosclerosis, for the Paget disease, as well as acute hypercalcemia, so for that we have the first line treatment is bisphosphonate. So bisphosphonate are those drugs whose name ends in dronates. So just remember the suffix dronate. So these are those drugs, such as you will have heard the etidronate, tyludronate. So these are these drugs. Now it includes the simple less effective etidronate, tyludronate, and amino bisphosphonate which are more effective, such as pamidronate and ravidronate and risidronate. Sorry about my throat is not all right. Now, if the sign and symptoms improve with bisphosphonate, it means that the pain is not due to the metabolic activity of the blastin class, but due to the complication. And we know the complication, which may be fractures, or it may be which I have previously described, the osteoarthritis may have been developed, or the osteosarcoma may have developed. So if those complications are developed, then you have to treat them accordingly. But mainly the symptoms, most of the time it improves with bisphosphonate. That's why the bisphosphonate is the first line therapy for the Paget disease. Moreover, calcitonin can also be used, but it is not first line therapy. Remember, calcitonin can be used in all those areas where bisphosphonates are used, but the bisphosphonates are the first line treatment. Now the calcitonin are given subcutaneously, and 100 to 200 units 3 times a week is given in this dose. So for the Paget disease, you have to remember the bisphosphonate and calcitonin. So these are, but basic first line treatment is the bisphosphonate. Thank you very much, and if you haven't subscribed my channels, do subscribe.